Dear ladies and gentlemen, thank you for the very kind invitation. I'm really unhappy not to be live there, but I'm happy to have the possibility to interact with you, even from the distance. Today we are talking about bipolar operation, bipolar procedures, and mainly about two different aspects, mainly non-muscle invasive bladder carcinoma and endoscopic enucleation of the prostate. Next, we all are aware that the majority of the tumors are non-muscle invasive, and we even noticed in the last decades that bladder carcinoma has developed to an increasing challenge because of the improved diagnostic possibilities, but also because of our societies which are aging in all Europe and increasing incidence. Next. The resulting increase in therapy costs gives everybody, every health system great problems, because we all are facing the problem of limited resources. Next. And already now we have the problem that bladder carcinoma is the most cost-intensive tumor entity because of the average cost per patient. Next. Although the majority are non-muscle invasive of the bladder carcinoma, we know that they tend to recur. The risk to progress, and this combination makes this tumor entity to a high socioeconomic burden. Next. Our management has not really very much changed in the last decades, and we still need cystoscopies, repeated cystoscopies. We are still doing 2 hours. We have been doing that for the last 90 years, more or less, since its introduction in the 30s of last century by Stern, for example. And we're still doing instillation therapies, also something which is not really so novel. Maybe there is some new agents coming in the market. IO, for example, is facing this scenario even in non-muscle invasive bladder cancer. Next. The current gold standard is still TURP, and as I was telling you, it has been introduced already 90 years ago. It obviously changed because of the changing and the improvement of technology, of the instruments, of the generators, but it is the same procedure we have been doing for the last 90 years. Next. And probably the most recent advantages we had have to do with the bipolar energy based systems, the unblock procedure as a switch to another aspect of technique, and what significantly probably changed our life as urologists is imaging introduced in endoscopy. Next. What can we say about bipolar? Bipolar technology is not per se novel, because we have been using bipolar systems in the last 20 years. What is the evidence in comparison to monopolar? If we look at, there are several meta-analyses. If we look at this one, it's rather recent. We know that bipolar produces a shorter operative time because the loops just simply cut better through tissue, and because of presumably less bleeding, We can remove patient's catheter earlier and so reduce the hospital stay of the patient. Next. We also are aware that also the complications went a little bit back with bipolar technology. This has been proven, not because the obturator nerve reflex completely disappeared. It is surely still present also with bipolar technology, but it is reduced. And therefore we have probably less bladder perforation than in the past. What surely disappeared, and only if this would be the only aspect which we have ameliorated with bipolar, TORZ syndrome has become rare. And if this would be the only aspect which is better, this would be enough for us to stuck to bipolar, because everybody who started with monopolar knows or remembers how aggressive TORZ syndrome was and how dangerous. Next. The postoperative recurrence rate in 2 years also showed advantages of bipolar TURP versus monopolar. At least in this meta-analysis, this is the only one which showed some advantage also in respect to postoperative recurrence, and only in the short term. Next. A sure advantage, which is very clear from this image, next, is especially the penetration depth of bipolar versus monopolar. And if you look at what energy you need for a coagulation or for a cutting, you see what the difference is, and the penetration depth is probably 5 times less with bipolar versus monopolar. Next. So does this mean that monopolar is not no longer existing worldwide? Next. Absolutely, this is untrue, because we are not all living in Europe, in north of Europe or in middle of Europe. So we also have to consider that there are countries with other economic standards and with other systems. So not only monopolar still exists because of economical issues, but there are also imitation of loops. Next. But obviously, if you can afford an original instrument, I think you would go for that also for a question of safety. Next. Regarding technique, as I was mentioning before, it's almost 100 years that we are resecting in the same way, and we have also to consider that as urologists, we are one of the only specialties in medicine, in surgery, which retrieves a tumor from the body by destroying it. And for bladder cancer, we are doing that. We are destroying a tumor in order to take it out, in order to have a specimen. And obviously, due to the endoscopes and to the width of the loops, we fragment the tumor. Next. The surgical technique is suspected of being involved in cell seeding. So by destroying the tumor, maybe we produce recurrences outside the resection area. Next. We also know that the accuracy of the initial TURP is decisive for the further prognosis of the patient. Next. If we look at, for example, the absence of detrusor in in the histological specimen, especially if it's a first manifestation of a tumor, we know that we will have a higher incidence of tumor persistence. We will face a higher incidence of early recurrence. And we obviously will delay a radical cystectomy because we need to go and look for the TRUSR with a second procedure. So we automatically, if we miss the TRUSR, deteriorate the prognosis. Next. We know that the TRUSR, if we look at literature, may be absent in up to 50% of the procedures. So this is a very obviously high rate, and obviously it never happens in our own department, but this is published literature. And if we consider that the prognosis of the patient can be spoiled, can be reduced by a misfunction of a surgical technique, you have, or we have to either improve our quality or to look for alternatives. And an alternative which is not so novel, because unblock procedures have been out there from the 80s, have been there and have been enhanced due to the better technologies we now have. Next, what is unblock? Unblock is the concept of removing the tumor in one piece by digging underneath the exophytic part of the tumor, going underneath the tumor itself without even touching the exophytic part. Next, and with the video, which we can start, you will see how I am doing the unblock procedure. I prefer a bipolar system, but obviously it works well also with other energy sources. The concept is always the same. The concept is to remove the piece in one, the tumor in one piece. I generally start with imaging modalities in order to appreciate the borders of the tumor. So I tend to use PDD or Image 1S technology by STORZ, or even combine both technology in first manifestation of bladder tumors. And what I do is to incise circumferentially the mucosa of surrounding the tumor, and I use those enhancing modalities in order to be sure that macroscopically I'm doing my incision in a circular way all around the tumor in a healthy looking tissue. So the goal is to start there where I don't see tumor. And we all know that we often have some aisles of tumors even millimeters away from the primary carcinoma. So having done this incision all around, I just decide where I want to go deeper. And you see by this very fast staccato movement of the yellow pedal, of the cutting pedal, you can very precisely cut the mucosa, and you can even decide how deep you want to get. Here you see a small bleeder of the papilla, of a papillary part of the tumor, and I'm coagulating it because it disturbs the view, which is generally outstanding when you do an unblock procedure, because you never touch the exophytic part, which is the part which is generally bleeding in a conventional TURB bladder. So having done the circumferential incision of the tumor, I just decide how deep I want to get. So Also here, I just do the same staccato fast movements with the cutting pedal. It's a combination of cutting and a little bit of blunt dissection. And I choose how much I want to get deep. With the new generators, for example, the Autocon from STORZ, you can very easily dose the quantity of energy just by moving very fastly the pedal. Yeah, this works even if you have an obturator jerk. Obviously, if it's massive, you need to go for a general anesthesia for a relaxation or do an obturator block. But you can do an unblocked procedure even just by doing very fast movements, even if you have an obturator jerk. You see the tumor is lifted up, it's luxated in the air, and you can leave it hanging on the border of the edge of resection in order to retrieve it out of the tumor, possibly through the sheath of the instrument. The only limit of the procedure is the size of the tumor, but you see, you always have a very nice and clear view. You can work close to the orifice without harming it, because it's very much in control due to this high quality energy source. I started my career many years ago with monopolar, and this absolutely was not the fact with the old monopolar system. Their life was much more complicated. Here I'm suffering a little bit longer in order to grab it in an elegant way with a bag, with an endoscopic bag, which actually is not really designed for endoscopy of the urinary tract. It comes from gastroenterology. So if you want, you can even do something like this. This is probably the most fancy way, but you just can grab the piece with the loop and take it out of the bladder through the sheath. Next, please. The limit is only the dimension of the tumor. Please, next. The video is starting again. Thanks. So as I was telling you, no matter which kind of technology you adopt, every technique is working and producing the same result. Whether you work with a J. Collins hook, bipolar, different laser systems, holmium, thulium, continuous wave, pulsed wave, the water jet, all have the same concept and same technique. Next, please. The aim of all those energy sources is to do an unblock procedure in order to reduce the spilling, in order to remove the underlying detrusor. Next, please. In order to maintain a distance to the tumor. If we look at literature, next, please, and briefly go into the details of histology, morbidity, and what's about recurrences. Next, please. Talking about histology, the main goal of is ameliorating histology, or one of the important goals of this procedure, because if you send a specimen in this form to the pathologist, he will become very happy. And you know that it's intuitive that the pathologist will have a much easier life to orient himself and will give you much more information if you send him something like this. Next, please. Next, please. A couple of years ago, we published our experience in different centers, and previous slide, if it goes back, otherwise we stay with this one. Yeah, this multi-center retrospective analysis of different institutions showed that the presence of the detrusor in the specimen of an unblocked procedure was more than 96% in the bipolar and monopolar unblocks, In the laser group, it even reached 100%. Next, please. And looking at literature, the average of published data is also far more than 90% of the presence of the trusor after unblock. Next, please. So these results reinforce the assumption that the endoscopic resection of bladder tumors can be improved by the unblock independently of the energy source. Next, please. And taking into account the underlying data, both perioperative and postoperative complications are classified as minors. That means if we look at literature, morbidity is not increasing with this technique. Next, please. A picture like this, a symptomatic perforation, is not so frequent. Probably it was more with monopolar. That's why this technique did not spread so much with the monopolar technology in the late 80s. Next, please. But if we look at what has been published recently in literature, Clavian grade 2 complication infections, UTIs, where 5% perforation were 6 out of 221. Next, please. And even looking at the published, rest of the published literature, you see on the light column very rare perforation in more than 500 patients. Next, please. Looking at the oncological results, we cannot at the moment say very much because the publications are very rarely homogeneous. Never or almost never we have information about early installation. All have different protocols. Next, please. But what we can surely already say that we can ask our pathologist to give us, and this is absolutely a novel thing, information about the margins. And they were in more than 90% in the published literature are 0. The outfield recurrence rate was more than 60%. That means we perform very well if we do unblock procedure. Next, please. Obviously, whether the unblock resection leads to the previously postulated improvement regarding a reduced recurrence rate cannot be conclusively clarified at the moment. We need more evidence. There are many ongoing prospective trials. Next, please. However, the result it presented in literature so far suggests a non-inferiority to the conventional TURP. Next, please. We surely, especially in smaller tumors, have improved histological outcomes due to reduced thermal effects, due to the inclusion of the trusor. Next, please. It is even possible, next please, to do a so-called re-in-block after having done, this is not a video, having done an en-block. So you can do a second look procedure again with unblock. We have published that in the World Journal a couple of months ago. This is the second part of my presentation, and it deals with enucleation of the prostate. And that's the loop. I just wanted to show it to you. I have adopted a couple of years ago. It has been designed by a colleague of us working in Switzerland, Professor Thomas Hermann. Next, please. Next, please. Why? Oh, back. Sorry. Why should we even start with an enucleation technique? Why should we implement our armamentarium for large prostates? Well, if we want to remove much tissue, we need enucleation of the prostate. If we have a large prostate, we need an enucleation technique, because the enucleation produces a drop of PSA of 80%. A conventional, well-done TURP, 60% at best. If we look at vaporization techniques, 40 to 45%. So if we need to remove much tissue in a large prostate, you need an endoscopic enucleation of the prostate. Next, please. And here I present a video with some technical aspects of how I'm doing the enucleation of the prostate. I start my incision always at the verum montano in a so-called U-type, inverted U-type incision, an omega incision all around the verum, in order to have a marking place, in order not to go back to the sphincter when I start my procedure. And also because at the apex of the prostate, lateral to the verum, it's pretty much easy to find the layer of the capsule. And we're adopting a resectoscope. It's a resectoscope with this particular loop inside, and the movement I do, it's the typical movement we all are used to when we do a conventional TURP or bladder tumor resection. So you see, just by doing this back and forwards movement of the loop, you find the layer of the capsule. You do that on the left side, on the right side, then you join the incision and you go to the middle lobe. We can do a 2-lobe, a 3-lobe technique when you do the one, when do you perform the other type. Well, actually, it has to do obviously with surgical experience and also with the presence of a very large middle lobe. The big advantage of the technique itself is that even doing this channel to divide the lobe is very easy with this system, because it's a conventional resectoscope. So you just vaporesect and do a broad channel. If you look at a laser enucleation procedure, doing those channels, especially in the beginning, is rather difficult, because the channel is with a laser very, very tiny, and the lobes tend to compress the channel, and so you struggle to find it again. I mobilize the prostate without even looking at the sphincter. I just follow the curvature of the adenoma. You see on the right lateral side the surgical capsule, on the left medial side the adenoma, and I just develop my plane until I reach more or less the 12 o'clock position, just by mainly a blunt dissection. I do this blunt dissection and do very small application of energy. So I just use energy if I have to divide some tissue bridges, or if I have to coagulate, but mainly the dissection is done bluntly. And it is done bluntly only by the tip of this fancy instrument, not by the beak of the instrument, like in conventional laser enucleation. Having done the incision at the 12 o'clock position in order to divide the lobe, the left from the right lobe, I incise the attachment of the sphincter to the apex of the prostate. You see this bridge at the 12 o'clock. This is this mucosa bridge, which is holding the apex of the adenoma to the sphincter. You don't have to touch there. You leave approximately 5 to 7 millimeters of tissue in order not to go too close to the sphincter, in order not to risk to injure the sphincter. So you just cut through this strip of mucosa, reaching the 12 o'clock position, reaching the channel we have just done a couple of minutes before. We detach the entire lobe until we have it hanging on the bladder neck, like you see here. I tend to leave it hanging on the lateral part of the prostatic fossa at the bladder neck, generally at the 3 and at the 9 o'clock position, in order to have it very easy and safe detached from the bladder neck. If you don't have the morcellator in the beginning of your experience, you just leave it hanging there and you can resect it very fast. But as soon as you have the possibility to buy a morcellator, go for a morcellator. Nowadays they are working very well. They are very safe and very fast. So the most important trick is probably have a nice view. That means you have to take your time to coagulate very extensively. Next, please. Literature is also very in favor of bipolar enucleation because we already have 5 randomized clinical trials. We have 2 cohort prospective non-randomized. We have already a very good systemic review comparing bipolar enucleation to bipolar TERP. Next, please. And it shows, let's look at the right part of the slide. You see that for all parameters, IPSS, Qmax, voiding residual quality of life, enucleation of the prostate performs better than bipolar TERP. Next, please. Also in this slide, look at the right. Oh, go back, please. Yes. On the right side of the slide, you see the randomized trials, and you see the overall complication rate is reduced in bipolar enucleation in comparison to TERP, bipolar TERP. And mainly it has to do with the reduced bleeding you face while doing a bipolar enucleation. Next, please. And although bipolar enucleation of the prostate had already demonstrated the equivalence to HOLEP in a randomized controlled trial already in 2006, this was the group of Frauendorfer who did this very interesting prospective trial. It took 2 further meta-analyses, 2015, to unveil the convincing evidence of enucleating techniques based on bipolar energy. Next, please. And these studies analyzed the results of randomized controlled trials comparing open prostatectomy with either holmium laser enucleation of the prostate or bipolar enucleation of the prostate. And they concluded the equivalence in regard to efficacy, to relieve the obstruction, and perioperative safety and long-term results. Next, please. That's why, consequently, 2016, the EAU guidelines promoted, after having received the results of those 2 meta-analyses, promoted both HOLEP and bipolar enucleation as the treatment of choice for benign prostatic obstruction in large volume prostatic glands. Next, please. So, having said that, we know HOLEP works well, bipolar enucleation works well. Now the academic discourse on anatomic enucleation moves more towards not defining which is the best technique, but probably we are looking now at some other further details. How can we prevent early postoperative stress urinary incontinence? How can we reduce retrograde ejaculation? How can we reduce irritative symptoms? Which is the best technique, 2-lobe, en bloc, 3-lobe? How can we ease the learning curve? Next, please. And I thank you very much for your attention, inviting you in Salzburg next year, hoping that our normal life is back again. Thank you very much.